Imagine this. You're sitting down to a really nice dinner.
Mm-hmm.
Maybe it's a first date, the kind where you've spent like 20 minutes just staring at your closet trying to find the right shirt, and you're trying to be charming.
High stakes.
Or maybe not. Maybe you're just incredibly hungry after a long day. You've ordered your favorite meal?
I'm picturing a Reuben sandwich, piled high with sauerkraut.
Perfect. Or a really crisp, tart apple, the kind that almost makes your jaw ache just looking at it because you know it's going to be sour.
Right.
You pick it up, you take that first bite, and you start chewing. And you're expecting that rush of flavor, the satisfaction of eating. But instead, something really bizarre happens.
Something that feels completely out of place at a dinner table.
Exactly. You feel moisture
Yeah.
dripping down the side of your face.
Ah.
And at first you ignore it. You think, okay, maybe I spilled my water, or
Yeah.
maybe the restaurant has the heat cranked up way too high.
Sure, you rationalize it.
You wipe your cheek with a napkin, but then you take another bite. And it happens again and again.
And just to be clear for everyone listening, we're not talking about being a messy eater here. You haven't, missed your mouth with the sandwich.
No, not at all. This is internal. You realize you are sweating profusely. But here's the kicker. It's only on one side of your face.
Wow.
And it happens exclusively when you chew. You stop chewing, the sweating stops. You start chewing again, the waterworks turn on.
It sounds like a glitch in the simulation, doesn't it?
It really does.
Like someone went into the code of the human body and just swapped the file for eating with the file for running a marathon.
It sounds totally fake, but it's very real.
Yeah.
It's not because the room is hot, and it's not because you're eating the world's spiciest curry. It's a physiological crossed wire.
A literal short circuit.
Today, we're diving into the strange, fascinating, and sometimes socially debilitating world of Freys syndrome.
Or, if we want to be technically precise, and given the stack of pathophysiology reports on my desk, we probably should be gustatory sweating.
Gustatory sweating.
Which, literally translates from the Latin as sweating related to tasting.
Sweating while eating. It's catchy in a slightly weird way.
Yeah.
Now, to set the stage for our listeners, we have a stack of clinical guides, surgical reviews, anatomy texts, stuff that's usually reserved for med students prepping for their board exams.
Right. Things like the USMLE or the NEAT PG.
These are dense reads. But our mission today is to crack these open and, well, translate them into human.
It is a fascinating topic. In the medical world, we call this a high-yield subject.
High yield.
Yeah, that means it comes up constantly in exams. And the reason isn't just because examiners are mean, though, some might argue that.
I'm sure they would.
It's because to understand Freys syndrome, you have to understand the anatomy of the face, the autonomic nervous system, wound healing, and surgery complications all at once.
It's the ultimate crossover episode of body systems.
It really is. It's a comprehensive test of a doctor's knowledge.
So here's the plan. We're going to look at how the body's own attempt to heal itself can sometimes result in these crossed wires. This fascinating mix-up where the urge to salivate gets translated into the urge to sweat.
And ultimately, it's a story about regeneration. That's the irony of it. It's about how the body tries to fix a problem, but because it's working without the original blueprints, it makes a very strange connection.
Okay, let's unpack this. We've dropped the name a few times, Freys syndrome. But let's get the official textbook definition on the table so we're all starting from the same place. What exactly are we looking at here?
Okay. So if you look at the clinical literature, the core definition is actually pretty straightforward, even if the mechanism is, super complex. Freys syndrome is defined as gustatory sweating and flushing over the parotid region, occurring specifically during eating.
Okay, I'm going to pause on parotid region. That's the key geography here. We need to orient ourselves. Where exactly is that?
Right. So everyone, just take your hand and touch the side of your face right in front of your ear and kind of down towards the angle of your jaw.
Okay.
That area is where your parotid gland lives. You have two of them, one on each side.
And the parotid gland is basically a saliva factory.
Precisely. It's the largest of the major salivary glands. It's the heavy lifter when it comes to making the saliva to help you digest food.
So the syndrome is tied directly to that specific location. It's not sweating on your forehead or your nose.
No, it's specifically over that parotid area right in front of the ear.
Got it. And you mentioned it involves flushing, too.
Yes. It's often a combination. You get hyperhidrosis, which is just the medical term for excess sweating, and vasodilation.
Meaning the blood vessels open up.
Exactly. It causes redness or flushing, so the patient's cheek might turn bright red and start dripping wet at the same time.
You also hear called auriculotemporal syndrome, which I have to say is a mouthful. Auriculotemporal. I assume that's referring to a nerve.
It is, and we will get very intimate with that nerve shortly. It's the highway where this accident happens.
Okay.
But sticking to the definition, the exam pearl, that little nugget of info that helps you answer the test question instantly, is just sweating while eating.
That's simple.
If a patient comes in with a wet cheek specifically during a meal, it's Freys syndrome until proven otherwise.
Okay, so we know what it is. But let's talk about the when. Is this something you're born with? Is it some, like, genetic quirk where your DNA just got a bit confused?
No, and that's a really crucial distinction. This is almost exclusively an acquired condition.
Acquired.
You are not born with these wires crossed. Your embryonic development got this part right. Something has to happen to break the original connection and force the body to rebuild it incorrectly.
And that something is usually surgery.
Correct. The vast majority of cases happen after a peritectomy.
Which is the surgical removal of that gland we just found on our faces.
Exactly.
Why would someone even need that gland removed?
The most common reason is a tumor. Fortunately, most parotid tumors are benign things like pleomorphic adenomas, but they still need to come out because they just keep growing. So the surgeon goes in to remove the gland.
Okay.
And that surgery, specifically what we call superficial or total parotidectomies, is the trigger.
That makes sense. You're going to remove a tumor, you're disrupting the tissue, you're digging around in a really complex area.
Exactly. It's a very crowded neighborhood under the skin there. Nerves, veins, arteries, glands, all packed in tight.
Is it only surgery?
Well, not only trauma to the side of the face, like a deep cut from an accident, or parotid abscesses, which are deep infections. Even the tumors themselves can sometimes cause enough disruption to trigger it. But surgery is the big one. It accounts for the overwhelming majority.
Here is where it gets really interesting for me, though. I was reading through the notes, and there's this detail about the timing that feels, well, it feels counterintuitive. You'd think if a surgeon cuts a nerve during the operation, the effect would be immediate. You wake up from surgery, eat some Jell-O in the recovery room, and bam, you sweat. But that's not what happens, is it?
No, and that is the classic trap. If a patient has moisture on their face the day after surgery or even a week after, it is almost certainly not Freys syndrome.
So what is it then? If my cheek is wet on Tuesday after Monday's surgery, what's going on?
If it's immediate, it's likely a fistula.
A fistula.
Yes, a salivary fistula, which is just a fancy word for a leak.
A leak.
It means actual saliva is leaking out of the remaining gland tissue or the duct because the wound hasn't healed shut yet. It's fluid leaking out. It's not sweat being generated by the skin.
Okay, so immediate wetness equals a leak. But Freys syndrome, it requires patience.
Freys syndrome takes time. We are talking weeks to months after the procedure.
Weeks to months.
The classic window is often 1 to 4 months post-op, sometimes even longer.
So why the delay? Why does the body wait 3 months to start acting weird?
Because it involves biological regrowth. The nerves have to actually regenerate. They have to grow back, travel through the tissue, and make brand new connections.
And that doesn't happen overnight.
Not at all. It's a slow, microscopic construction project.
Is there, like, a speed limit for nerve growth?
Generally speaking, peripheral nerves regenerate at a rate of about 1 millimeter per day.
Wow.
So if that nerve has to travel a few centimeters to reach the skin, that's going to take weeks.
That is a wildly cool, if slightly unfortunate detail. It's like a time bomb.
It is.
You think you're fully recovered, the scar is healing, everything's fine, and then 6 months later, boom, sweaty sandwiches.
It catches a lot of people off guard, and because it happens so late, patients often don't even connect it to the surgery they had half a year ago.
Right.
They just think they're developing some weird new food allergy, or maybe they think they're going crazy. They go to their GP and say, I sweat when I eat cheese. And if the GP doesn't know their surgical history, it sounds nonsensical.
So we have the what sweating while eating. We have the when months after parotid surgery. Now, I want to get into the why. I want to pop the hood and look at the wiring of the face because this seems like a major design flaw.
It's less of a design flaw and more of a repair flaw.
A repair flaw.
Yeah. To understand it, we have to look at the normal anatomy first. We need to trace the circuit. Under normal circumstances, before any surgery, how does your body know to make saliva?
I assume the brain sends a signal. It sees a burger and says, food incoming, prepare the enzymes.
Right. But let's trace that signal like we're following a car on a map. The signal starts in the brainstem. It travels down a very specific pathway. It starts with the glossopharyngeal nerve.
Glossopharyngeal, that's cranial nerve 9, right?
Correct. Glosso means tongue. Pharyngeal means throat.
Mm-hmm.
But this nerve has a side hustle, carrying instructions for saliva.
Okay.
So the signal travels down the glossopharyngeal nerve through a little relay station called the otic ganglion.
Relay station.
Think of it as a distribution hub or a train station where passengers switch trains. The signal comes in on the glossopharyngeal line and it hops onto a new line, the auriculotemporal nerve.
The auriculotemporal nerve, that's the one with the difficult name, the power cable we mentioned earlier.
That's the one. And the name actually tells you where it goes. Auriculo implies the ear. Temporal implies the temple region. It runs right through the parotid gland.
Okay.
Think of the auriculotemporal nerve as the dedicated delivery driver for the parotid gland. It carries what we call parasympathetic secretomotor fibers.
Let's break that down. Parasympathetic secretomotor fibers.
Parasympathetic is the rest and digest part of your nervous system.
Right. It handles things like digestion, salivation.
And secretomotor means it's a motor nerve that tells a gland to secrete fluid.
So normally,
Yeah.
brain sees food, sends a signal down the glossopharyngeal nerve, it hops to the auriculotemporal nerve, the parotid gland turns on, and saliva happens.
Perfect. That is the intended workflow. That's the factory setting. Now, let's introduce the chaos of surgery.
The parotidectomy.
Right. So when the surgeon removes the parotid gland, they have to be incredibly careful because the facial nerve, the one that controls your smile, your ability to blink, to raise your eyebrows, it runs right through the middle of the gland.
Talk about high stakes. You're dissecting a tumor off the nerve that controls someone's entire face.
Exactly. The surgeon is laser focused on saving that facial nerve. But in the process of taking out the gland tissue, those tiny parasympathetic nerve fibers, the delivery drivers we just talked about, they're inevitably cut.
Yeah.
They go into the gland that's being removed. There's no way around it.
Okay, so the wire is cut, the signal stops, the delivery driver hits a roadblock.
For a while, yes. The end of the nerve is now just sitting there in the surgical bed, severed. But the nervous system is resilient. It wants to heal.
Wants to reconnect.
It does. It's a property called neurotropism.
Neurotropism?
Yeah. It means the nerve endings actively grow and seek out a connection. So during those weeks and months of recovery, those severed nerve endings start to sprout. They act like little vines looking for a trellis.
But the trellis is gone. The parotid gland is in a biohazard bin somewhere.
Exactly. The original house they were delivering to has been demolished. But the nerve fibers are still growing blindly, looking for something, anything to plug into.
Okay.
And this is where the anatomy gets tricky. After the gland is removed, the surgeon takes the skin of your cheek, and lays it down right on top of the area where the gland used to be.
So the skin is now sitting directly on top of these cut nerves.
Correct. And what's in the skin?
Sweat glands. And blood vessels.
And tiny cutaneous blood vessels.
I think I see where this is going.
The regenerating parasympathetic fibers are growing upward, and they just run right into the sweat glands in the skin. And because they are so desperate for a connection, they basically say, close enough.
No way.
They plug into the sweat glands and the cutaneous blood vessels instead of the salivary gland.
That is wild. It's like the electrician shows up to wire the doorbell, realizes the front door is missing, so he wires the doorbell button to the fire sprinklers instead.
That is a fantastic analogy, and crucially, it's strictly a hardware problem.
Right.
The software, the brain is working perfectly. The brain sees the sandwich, sends the correct signal, stimulate fluid production. The nerve carries that signal correctly, but because it's plugged into the wrong outlet.
The result is sweat instead of saliva.
Exactly.
It's incredible that the body allows this. Why can a nerve just plug into a sweat gland? Don't they speak different, chemical languages?
That is the million-dollar question, and the answer comes down to biochemistry. Nerves communicate using chemicals called neurotransmitters. The parasympathetic nerves that control saliva use a neurotransmitter called acetylcholine.
Okay, acetylcholine, that's the key.
Right. Now, typically, sweat glands are controlled by the sympathetic nervous system, the fight-or-flight system, but, and this is a weird quirk of human biology, the sympathetic nerves that talk to sweat glands also use acetylcholine.
Wait, really? I thought fight or flight was usually adrenaline.
Usually, yes. Most sympathetic nerves use norepinephrine, which is basically adrenaline, but sweat glands are the exception. They use acetylcholine.
So it's the universal language for secrete fluid in this part of the body.
You got it. The sweat gland doesn't know it's getting a signal from a saliva nerve. It just feels the acetylcholine key in the lock and turns on.
It's a case of mistaken identity at the cellular level?
Precisely. The nerve fibers can't tell the difference, and the gland can't tell the difference. They both use the same key for the lock.
And the flushing. The redness that people get, what about that?
That's because those wandering nerves also connect to the tiny blood vessels in the skin. The signal tells the vessels to dilate, which is what blood vessels and salivary glands do to bring in more water for saliva. So on the skin, it just looks like a bright red flush.
And this whole process is called aberrant nerve regeneration.
Aberrant nerve regeneration. Aberrant basically meaning wandering off the path.
So you have a physiological crossed wire. Every time you think about food or chew, your cheek thinks it's time to cool down from a workout.
Exactly. And remember, this is why that delay exists. It takes time for those nerves to physically grow from the cut end up into the skin and establish that new connection with the sweat glands.
It really highlights how mechanical our bodies are. We think of eating as this holistic thing, but really it's just a series of electrical switches. And if you swap the wires, you get a different output.
And that output can be quite distressing for the patient, which brings us to what this actually looks like in the clinic.
Right, we talked about the wet cheek, but let's paint the full picture. If I have Freys syndrome, what's my day-to-day life like? Is it painful?
Well, the good news is that it is usually painless. The nerves involved are motor nerves, not pain sensory nerves. So patients don't complain of their face hurting while they eat.
That's good news. But I imagine the social aspect is brutal.
It is. The primary complaint is embarrassment. Imagine being in a business lunch, trying to close a deal. You're focused, and suddenly you have beads of sweat just dripping down one side of your face.
It signals nervousness, right, even if you aren't nervous. Sweating is a universal sign of stress.
Exactly. It creates a total disconnect between how you feel and what your body is projecting. Patients often resort to carrying handkerchiefs or constantly wiping their face, which, just draws more attention to it.
I can see how some people would just start avoiding eating in public altogether.
They do. They can become socially isolated because of a sweaty cheek.
And the triggers are specific, right? It's strictly chewing.
Mastication chewing is the main one. But also, the type of food matters.
Yeah.
Foods that stimulate strong salivation, we call them sialagogues, can make it way worse.
Like what?
We're talking lemon, vinegar, spicy foods, anything that really makes your mouth water.
Because if it makes your mouth water,
It will make your cheek sweat. The brain sends a stronger signal for those foods, and a stronger signal means more sweat.
so no Sour Patch Kids for these folks.
Probably not advised if they want to stay dry.
Now, you mentioned earlier that doctors have to be detectives here. If someone comes in with a wet face, how do you know for sure it's Freys syndrome and not something else? What are the imposters?
Right, so we touched on this, but it's crucial. The two main things you need to rule out are a surgical site infection and that salivary fistula we talked about.
Okay, let's break those down. Infection seems obvious. Is it red and angry?
Exactly. If it's an infection, the area will likely be swollen, red, painful, maybe leaking pus. It might feel hot to the touch. The patient might have a fever. Freys syndrome has none of that.
No pain, no pus, no fever.
Right.
And the fistula, the leak of actual saliva.
Right. A salivary fistula is a leak from the remaining parotid duct system. And the key distinction there is the behavior.
How so?
A fistula might drip constantly. It might pool under the skin. Freys syndrome is timed perfectly with the act of eating. It has an on-off switch controlled by chewing.
So if you're just sitting there watching TV, not eating, and your cheek gets wet,
That is not Freys syndrome. It needs that stimulus.
got it. So clinical observation gets you most of the way there.
Yeah.
But I love the next part of the source material. There's a way to visually prove this, and it sounds like a high school chemistry experiment.
Oh, the minor starch iodine test. It is a classic. It's the definitive way to map the syndrome. It's so low-tech, so cheap, but incredibly effective.
Okay, walk us through this. How do we turn a sweaty cheek into a map?
It's very simple. First, you take iodine, like the orange antiseptic liquid from a first aid kit, and you paint it over the patient's face where you suspect the problem is. You let that dry completely.
Okay, so now they have a yellow-orange face. They look a bit like they had a bad spray tan.
Pretty much. Then you take plain starch powder, cornstarch works perfectly, and you just dust it lightly over the iodine.
So now the patient looks like a powdered donut.
A powdered donut, yes. Very dignified so far.
Medical science at its finest.
But then, the final step, you stimulate the system. You give them a lemon wedge to suck on, or a piece of chocolate or something chewy. You jumpstart that salivary reflex.
And then,
And then you watch. As the nerves fire and the sweat glands start pumping out moisture, the water from the sweat mixes with the starch and the iodine. And, basic chemistry tells us that starch plus iodine plus water creates a reaction.
what kind of reaction?
A color change. It turns a deep blue-black color, almost purple.
So dark spots just start appearing on their face.
Exactly. You'll see these distinct blue-black dots or patches emerging on the white powder. It creates a perfect visual map of exactly where those aberrant nerves have connected to the sweat glands.
That is so cool. It's like developing a photograph. You can literally see the footprint of the crossed wires.
It creates indisputable proof, it confirms the diagnosis, and it also shows the extent of the area involved. And that map is vital if you plan to treat it.
Speaking of treatment, let's get into that. You have a patient, you've done the powdered donut test, they have blue spots on their cheek, they're embarrassed. What do we do? Do we have to do surgery again?
Not necessarily. In fact, surgery is rarely the first option for treatment. We usually follow a stepwise approach. And the first step might surprise you. Often, we do nothing.
Nothing. That seems anticlimactic.
Well, we call it conservative management. A lot of patients have really mild symptoms. Maybe a tiny patch of sweat they barely notice. Once you explain to them, hey, this isn't cancer coming back, it's just a crossed wire, many of them are fine with just that reassurance.
That makes sense. The fear of the unknown is often worse than the symptom itself.
Exactly. But if it bothers them a little more, we can try simple antiperspirants, just like you use under your arms.
You mean literally stick deodorant on your face?
Well, usually a clinical strength lotion or cream that has aluminum chloride. You apply it to the facial skin. It works the same way it does in your armpit. It physically blocks the sweat ducts so the fluid can't get out.
Simple, low tech.
But it can be irritating to the scare on the face, which is more sensitive, so it's not for everyone.
But what if it's severe? What if it's really impacting their life? What if they're that person at the business dinner, terrified to eat?
Then we bring out the heavy hitter. The gold standard for treating Freys syndrome today is botulinum toxin.
Botox.
Botox.
Usually we associate that with smoothing out wrinkles or, freezing foreheads. How does it help with sweating?
It comes right back to the chemistry we discussed earlier. Remember acetylcholine? The key that turns on the sweat gland.
Right, the neurotransmitter.
Well, Botox is a neurotoxin. Its specific job is to block the release of acetylcholine from the nerve ending. So, using that starch iodine map we made, you inject tiny amounts of Botox into the skin intradermally in the affected area.
So the nerve fires, but...
The nerve tries to yell, "Sweat!" But the Botox has cut the phone line. It prevents that chemical from ever being released. The signal never reaches the gland.
That is brilliant. It's cutting the line of communication without actually cutting the nerve.
Exactly. It effectively paralyzes the sweat gland chemically, and it is highly effective. The sweating just stops.
But Botox wears off, right? People have to get their wrinkles redone every few months.
It does. It's a temporary fix. But interestingly, in Freys syndrome, it tends to last longer than it does for wrinkles. We often see relief for 6 to 12 months, sometimes even longer.
Right.
So the patient might need an injection once a year, which is a very manageable trade-off for staying dry.
Is there any downside besides the needle?
Well, it can be expensive, and you have to be skilled. If you inject it too deep, you might hit the facial muscles underneath.
And then what? You paralyze their smile.
Potentially, yeah. You could cause a droopy lip or an asymmetric smile, but if it's done properly just into the skin layer, it's very safe.
So we have reassurance, antiperspirants, and Botox.
Yeah.
What about creams? I saw glycopyrrolate in the notes.
Yes, topical anticholinergics. Glycopyrrolate is a drug that blocks the acetylcholine receptor. So instead of stopping the signal from being released, like Botox...
It puts a lock on the receiver so the key doesn't fit anymore.
Right. It works, but it can be messy to apply. And if it gets absorbed systemically, it can cause side effects like dry mouth or blurred vision. Botox is generally preferred these days because it stays local.
Now, we've talked about fixing it once it happens. But can surgeons stop this from happening in the first place? If I'm going in for a prostatectomy tomorrow, can my surgeon do something to prevent this?
That is the holy grail prevention. And yes, there are surgical techniques. The concept is basically to build a wall.
A wall.
A barrier. Remember, the problem is that the cut nerves in the parotid bed grow upwards into the skin. If we can put something impenetrable between those nerve endings and the skin, they can't connect.
Like putting a tarp down before you paint the ceiling so you don't drip on the floor.
That is a perfect analogy. Surgeons use what are called interposition flaps. After they remove the gland, they have a hole or a depression in the face. Before they close the skin, they fill that space with other tissue.
What kind of tissue?
They might rotate a piece of muscle, like the sternocleidomastoid muscle from the neck, or they use a layer of fascia, the tough connective tissue covering muscles, or they use the SMAS layer.
The SMAS layer, I've heard of that.
Yeah, that's the layer plastic surgeons tighten during a facelift.
So they just lay this tissue down over the nerve bed before closing the skin.
Correct. It acts as a biological shield. So when the nerves start regenerating, they grow up, they hit this muscle flap, and they basically say, well, nowhere to go here, and they stop.
It's fascinating that the solution is basically put a rug over it.
Sometimes the simplest mechanical solutions are the best. It significantly reduces the incidence of Freys syndrome. Not 100%, but it helps a lot.
Okay, we have covered a ton of ground. We've gone from the dinner table disaster to microscopic nerve growth to the powdered donut test and finally the Botox fix. Before we wrap up, I want to do a quick rapid-fire review.
Let's do it.
The source material lists some common exam traps, things that trip people up. Let's test ourselves.
Okay, I'll give you a statement. You tell me if it's true or false regarding Freys syndrome.
I'm ready.
Statement 1. A patient comes in 24 hours after surgery with clear fluid leaking from the wound. This is Freys syndrome.
False. That is way too soon. Freys syndrome takes weeks or months to develop. That patient has a fistula, a leak.
Spot on. Statement 2. You should treat this patient with antibiotics because the redness indicates an infection.
False again. The redness is flushing from the nerve signal telling the blood vessels to open up. It's not inflammation from bacteria.
Correct. Antibiotics would do absolutely nothing. Statement 3. The best way to cure the underlying problem is Botox.
Ooh, tricky wording. Cure. I'm going to say false. Botox is the best treatment for the symptom, but it doesn't cure the underlying wiring, right? It just masks it.
Exactly right. It treats the symptom, not the cause. The wiring remains crossed. The Botox just keeps the switch off.
Okay.
And finally, this condition is caused by damage to the facial nerve.
Wait. We talked about the facial nerve being the one surgeons are scared of.
Yeah.
But no. It was the auriculotemporal nerve that was causing the sweating.
You nailed it. That is a classic trap because the facial nerve is the celebrity of the face. But Frey is all about the auriculotemporal.
Ah, good one. The facial nerve moves the face. The auriculotemporal, in this case, wets the face.
You've got it.
So, to summarize our deep dive today, Freys syndrome is a delayed complication of parotid surgery, where regenerating nerves get confused and plug into sweat glands. It's diagnosed with the starch iodine test, and if it bothers you, Botox is your best friend.
That is a perfect summary.
You know, stepping back from all the medical details, this whole topic really makes you appreciate the complexity of the human body. We talk about healing like it's this magical, perfect process. But actually, healing is messy. It's biological trial and error.
It is. The body is so resilient, it refuses to leave a wire cut. It will try to reconnect it, but it lacks the precision of the original development. It just prioritizes connection over function.
It's a reminder that we're biological machines, and sometimes the repair crew gets the blueprints wrong.
Absolutely. And it also makes me think about how much we take for granted. The autonomic nervous system, the stuff that just happens. Breathing, heart rate, sweating, salivating.
Right.
We don't think about them until they go wrong, and suddenly eating an apple becomes this complex social calculation.
It really teaches us to listen to the patient. When someone says, this weird thing happens when I do X, it's usually not in their head. It's usually a clue to a very specific, very logical mechanism, even if it sounds like science fiction.
Absolutely.
So next time you sit down to a meal, maybe just take a second to appreciate that when you chew, your mouth waters and your forehead stays dry. It's a small victory of correct wiring.
Indeed it is. A victory we should all celebrate.
That's it for this deep dive into the crosswires of Freys syndrome. Thanks for sweating the details with us.
Always a pleasure.
We'll catch you on the next one. Stay curious and stay dry.